I want to welcome you to our final workshop session of the 2021 Chisholm 83rd Annual Gathering. I'm Paula Barker, Senior Executive Assistant for Events and Administration with Chisholm, the Council for Health and Human Service Ministries. You're attending the workshop entitled There's a Reason to Have Hope, a Public Health Response to Racism with Elise Berry. I'm pleased to be able to introduce my colleague, the Reverend Dr. Elise Berry, who serves as Associate for Advocacy and Leadership Development with Chisholm. I look forward to hearing Elise present on how responding to racism as a public health crisis can produce hope. After Elise's presentation, there will be a time for Q&A and discussion. You are welcome to enter your comments and questions in the chat at any time.
Hello and welcome to the workshop Reason to Have Hope, a public health response to racism. I'm Reverend Dr. Elise Berry, and I'm delighted that you decided to join me for this presentation today. First, I'd like to just say that located in Cleveland, Ohio, Chisholm acknowledges that we reside on the traditional homeland of the Lenape, Shawnee, Wyandot, Miami, Ottawa, Potawatomi, and other Great Lakes tribes who have stewarded this land for generations. We also acknowledge that the thousands of Native Americans who now call Northeast Ohio home. I work for Chisholm as their Associate for Advocacy and Leadership Development. I use the pronoun she, her, hers. And I'd also like to offer an image description of myself. I'm a white woman with blonde hair, blue eyes, who's wearing a white beaded necklace, a black shirt with yellow flowers, and behind me is my white bookshelves. So the objectives for today's workshop are to define what public health is as a discipline, explain why we must focus on racism as a threat to health and well-being, discuss the social determinants of health and health disparities, define health equity, and give examples of the work being done to bring it to life, and finally, to envision and wonder together, what is God calling you to do? Before we jump into the main content for today, I'd like to start with scripture and story to ground us for this conversation. Let us take these words from Isaiah 65. For I am about to create new heavens and new earth. No more shall the sound of weeping be heard in it, or the cry of distress. No longer will there be in it an infant who lives but a few days, or old people who do not live out their days. At last they will live in the houses they build and eat the fruit of the vineyard they plant. What do you notice here? When I read this, I envision a life of potential, joy, fullness of life, housing, nourishment of body and spirit, and that this is for everyone, not just a few. I also hear an acknowledgement that this is not currently the case, and our current reality is not what God desires. What happened to Dr. Susan Moore is not what God desires. On November 29th, 2020, Dr. Moore tested positive for COVID-19 and was admitted to the hospital. She reported that a white doctor had downplayed her complaints of pain, telling her that he felt uncomfortable giving her more pain medication and suggested that she be discharged. On December 4th, she posted a video on Facebook where she described how she had to advocate for herself with the medical staff to get the treatment and respect that she deserved. She said that she had to beg for a physician to give her an antiviral drug used to treat COVID-19. I put forth and maintain if I was white, I wouldn't have to go through this. This is how Black people get killed, when you send them home and they don't know how to fight for themselves, she said in a video, not only as a Black woman, but as a medical doctor herself. The hospital released her on December 7th, and she was sluggish and tired when she got home. The hospital called several times to check up on her, and when she didn't respond, they sent an ambulance. She was taken to a different hospital only 12 hours after being discharged from the previous one. Over the following days, she became ventilator dependent and subsequently died. What happened in Flint, Michigan is not what God desires. As you may remember, in April of 2014, the city of Flint entered a state of financial emergency due to the Great Recession. State, city, and county officials collectively decided to save money by switching to a new water source. Instead of partnering with Detroit Water as they had in the past, they'd utilize a new pipeline to draw less expensive water from Lake Huron. As a temporary fix to start saving money while that pipeline was being completed, the city began drawing its water from the Flint River, something it had not done since the 1960s. The recipients of this water source were predominantly a Black community, while the surrounding predominantly white communities continued to receive clean Detroit water. Not long after, residents started to complain about strange odors and brown water coming out of their pipes, and government officials simply ignored them. By the time the EPA notified Michigan of the dangerous levels of lead in Flint's water, they found that Flint had been exposing its residents to lead at levels that could cause lifelong damage to the health of its children. The levels of bacteria also likely caused an outbreak of Legionnaire's disease, killing at least a dozen people in those few months. The tragedy is not only in the water crisis itself and with the massive mishandling of the response that came after, but in how residents no longer have any trust in their government, reasonably so. And this issue has risen to a head in the current pandemic as well. These stories bring me to another verse in Isaiah. While God calls each individual person to work for an equitable society, Scripture also clearly articulates a call for systemic change. As Isaiah 10 says, "Woe to you who make unjust policies and draft oppressive legislation, who deprive the powerless of justice and rob poor people, my people, their rights, who prey upon the widowed and rob orphans." In a famous sermon at Riverside Church, Dr. Martin Luther King called on us to not only respond as the Good Samaritan did, with compassion for the suffering we encounter, but to ask, why was the road to Jericho so dangerous to begin with for this poor traveler? Why is it that a person is left for dead on the side of the road and their only hope is left upon the kindness of one person, rather than on a society that fosters and sustains safety for all? This brings me to public health, a discipline that heeds the call of Dr. King to examine and rebuild this proverbial road to Jericho. According to the American Public Health Association, public health promotes and protects the health of people and communities and environments in which they live, learn, work, and play. It does not just look at an event or an illness in isolation. Public health examines the whole system and the root causes that lead to widespread illnesses or accidents. How do the factors of your daily life impact your health? This is done through assessment, like data collection, monitoring health needs, investigation, and addressing these root causes. It is done by providing assurance, by educating the public about health, how to protect themselves, and how to build a diverse and trustworthy workforce to do that work. And finally, they focus on policy development by using governmental and legal systems to do so. Thus, it is systems levels thinking with system levels solutions. Public health perspectives are also grounded in a human rights framework that advocates for health as a right without making a distinction of who is deserving or undeserving. I think it's important to include here language about well-being in addition to health, because all too often in our ableist society, health is understood narrowly as the absence of disease and disability. But I believe that no body is disposable or can be deemed less worthy of care or incapable of wholeness just as they are. This systems level thinking is so vital because the health hazard we are talking about today is systemic and must be understood that way. For some, racism is still thought of as only the KKK or Nazis. While that is certainly true, according to Ibram X. Kendi, racism is a marriage of racist policies and racist ideas that produces and normalizes racial inequities. It thus includes both the personal beliefs and biases we hold, and why we hold them to begin with, and the systemic policies, norms, and values that cause oppression on such a large and pervasive scale. This normalization was striking as data started to come out about racial health disparities for COVID at the beginning of the pandemic. As Kendi wrote in an article for The Atlantic, quote, "Americans are blaming Black people. To explain the disparities in the mortality rate, too many politicians and commentators are noting that Black people have more underlying medical conditions, but crucially, they're not explaining why. Or they blame the choices made by Black people, or poverty, or obesity, but not racism. According to this logic, racism is not murderous. Black people are killing themselves," end quote. Black people are to blame for their untimely deaths. And this is a dangerous way of understanding reality indeed, of accepting these disparities as the norm and placing the blame all on the individual, which then relieves everyone else from doing anything about it. White supremacy wants to tell us that this is just the way that it is, and nothing systemically would change it. Yet we have 35 years of research showing how racism undermines the health and well-being of people of color. And the stories of Dr. Moore and Flint are stories of choices that were made, and we can make better ones. Further, this workshop focuses on race and because racial inequities persist in every system without exception, and show up in other dimensions of identity, like gender or sexual orientation. Knowing this helps us to take a more intersectional approach, while always clearly naming the role that racism plays in people's health. This is a philosophy similar to that of the Combahee River Collective, which teaches if Black women were free, it would mean that everyone else would have to be free, since our freedom would necessitate the destruction of all systems of oppression. And this continues to be proven true. In his book, Dying of Whiteness, physician and researcher Jonathan Metzl explains how the frameworks of white racial resentment have shaped attitudes towards public policy, which not only lead to an increase in mortality rates for people of color, but also for the white voters who support the very policies that are killing them too. As Metzl tells through a patient narrative who lacked insurance, quote, "Ain't no way I would ever support Obamacare or sign up for it. I would rather die," end quote. When he was asked why he felt this way, even as he faced severe illness and death, the patient explained, quote, "We don't need any more government in our lives. And in any case, no way I want my tax dollars paying for Mexicans or welfare queens," end quote. Moreover, a third of Americans do not see systemic racism as a barrier to good health, even after communities of color have been hit the hardest by COVID, and that is not lost on anyone. According to a national survey released in January of this year, supplied this data. As one of the researchers pointed out, our leaders need to understand that we have a lot more work to do to educate people about the root causes of inequities, and then enact policies to ensure better health for all. Framing racism as an issue of public health also rallies faith communities, organizations, and the government to address this crisis through systemic change, in the same way other threats to public health have been addressed. such as through policies, enforcement, education, and support services. It also brings together resources and efforts around the same cause. And the framework of public health helps us to identify, where do we fit into this collective effort? Do we see ourselves fitting in the work of assessment, assurance, policy development, or perhaps all of the above? So how does racism impact health specifically? We begin by identifying what are called social determinants of health, the conditions in which people are born, grow, live, work, and age that impact health. These are shaped by the distribution of money, power, and resources. Social determinants are mostly responsible for health inequities and health disparities, which are the unfair and avoidable differences in health status between populations, which are due to past and current unjust policies. However, medical care is also estimated to account for 10 to 20% of why we have health disparities as well. This percentage, though notably smaller than social determinants, is not something to be glossed over either. Dana Bowen Matthew, in her book, Just Medicine, illustrates how Black and Brown patients consistently receive inferior medical treatment than their white counterparts. They are sicker and more likely to die than white patients from a wide range of illnesses. And these disparities persist even after for controlling differences in insurance status, income, education, etc. This is why I wanted to ground this workshop in the stories of both Flint, Michigan, and Dr. Moore, to paint a fuller picture of why, as Bowen articulates, quote, "It is estimated that nearly 84,000 minority patients die annually due to healthcare disparities." Social determinants of health include, but are not limited to, social norms like racism, homophobia, sexism, ableism, exposure to violence, income, housing, transportation, food, healthcare access, the quality of the healthcare, environmental health, etc. For decades, research has connected racism in mortgage lending, access to housing, employment, and the criminal justice system to racial health disparities. While poverty is clearly a main contributing factor and the huge racial wealth gap cannot be ignored, again, we must hold that it does not account for every disparity. For example, Black Americans across the income spectrum are dying from preventable pregnancy-related complications at 3 to 4 times the rate of their white counterparts. And the underlying variable shown up in this research, the difference, is racism. A brief overview of specific health disparities for Black, Indigenous, and other people of color include lower life expectancy, higher infant and maternal mortality rates, higher rates of diabetes, hypertension, heart disease, and asthma, and poorer treatment for pain, cancer, cardiovascular conditions, mental health, and even end-of-life care. The COVID-19 pandemic has really been a case study for racism as a public health crisis, and it is becoming more commonplace for it to be discussed this way. Research from the New England Journal of Medicine and the Journal of Clinical Investigation, for example, make clear that structural racism has been proven to be a barrier to COVID-19 treatment and prevention. This shows up as higher mortality rates, higher infection rates, in the link of these rates to economic stability and healthcare access, to living in multi-generational homes, which people of color are more likely to do, and to working in jobs deemed essential, also which people of color are more likely to do. It is essential to include state-sanctioned violence in this conversation about health disparities and the social conditions that cause them as well. Black people are 3 times more likely to be killed by police and are more likely to be unarmed in those killings than those who are white. Research also shows that the mere presence of high use of force by police in communities of color is associated with an increased risk in poor health in those communities. Poor data collection by law enforcement has contributed to the crisis of missing and murdered Indigenous women, and Black prisoners are more likely to die by state execution than those who are white for the same crimes. And this terror cannot be mentioned without stating the lack of accountability. Between the years 2013 and 2020, 98.3% of killings by police have not resulted in officers being charged with a crime. Included in my analysis of state-sanctioned violence is our immigration system and ICE. Research shows that immigration status overall directly influences health outcomes, but it must be named that migrant detention centers have a long history of medical neglect and abuse, including preventable deaths of children. And research has shown that family separation has long-term damaging psychological and health consequences for children, families, and communities. Finally, another aspect of this is mass incarceration and the war on people who use drugs. The US incarcerates a higher percentage of its citizens than any other country in the world. What's often overlooked in this discussion, though, is the damage that prisons and jails do to our health, from those who are incarcerated to their family members and those who work in them. Perhaps not surprisingly, suicide is the leading cause of mortality in US jails. Poor nutrition, restrictions on physical movement, overcrowding, lack of privacy, poor sanitation, poor ventilation, etc., create oppressive living conditions, particularly during a pandemic, where 1 in 5 prisoners has contracted COVID as of the time of this recording. 60% of the 2.2 million Americans incarcerated are Black or Latinx. Black people are also nearly 6 times more likely to be incarcerated for drug-related offenses than those who are white, despite equal substance use rates. And 72,000 people died from drug overdoses in 2019, a crisis that public health experts have said is mostly fueled by socioeconomic inequalities, trauma, and hopelessness. If you ever find yourself wondering if policies in today's world really are directly racist, I uplift the war on people who use drugs as an example that this indeed can be the case. John Ehrlichman, who helped Nixon create these policies, confessed in a 1994 interview that, quote, "We knew we couldn't make it illegal to be either against the war or Black, but by getting the public to associate the hippies with marijuana and Blacks with heroin, and then criminalizing both heavily, we could disrupt those communities," end quote. I realize how overwhelming and dense what I just presented can be, but this next half of the presentation is where we find hope, now that we've named the gravity of the issue so we can accurately respond to it. Health equity implies that everyone should have a fair opportunity to attain their full health potential, and that no one should have barriers to that potential. Further, health equity and health equality are not the same, though the words are often used interchangeably. Equality means giving everyone the same thing, whereas equity means giving people all of what they need to reach their best health. I think a strong example of this comes from the city of Asheville, North Carolina, which in July of 2020 unanimously approved a reparations policy for its Black residents. They're doing this through funneling money into increasing Black home ownership, business ownership, closing the gaps in healthcare, education, pay, neighborhood safety, and fairness in the criminal justice system, etc., which sounds an awful like social determinants of health, does it not? As I mentioned earlier, a public health response broadly involves assessment, assurance, and policy development. So I'm going to give a few examples of faith-based communities engaging on these different fronts. In this first category of assessment, you'll notice examples of interventions that tackle the spectrum of social determinants of health. The first example comes from Chisholm member advocate Aurora Health System, who has been a national leader in health equity efforts and in declaring racism as a public health crisis. I highly recommend going to their Center for Faith and Community Health Transformation website to learn about the breadth of their work in particular. The story I'd like to uplift relates to assessment and a new program the hospital has implemented called NowPal, a mobile-enabled messaging and referral platform that gives them the ability to prescribe non-medical resources for their patients. Care managers and other providers have already been screening patients for needs around food, housing, transportation, and other social determinants. But the platform can then use that screening data with a database of over 11,000 community services to connect patients with the services specific for them in their neighborhood. Thus, it helps to close the loop between the clinical and community service providers. So, if your congregation has a food ministry, offers English as a second language or classes, or facilitates grief support groups, one question you could start asking yourself is, do your local hospitals know this so that they can also make these connections? If you're a health and human service organization, what is your relationship like with churches and other medical providers? This kind of collaborative work helps us to realize that you don't necessarily have to start a whole new ministry. Because racism is everywhere, and because all of the structures of daily life impact health, then that also means that the possibilities are actually endless with where you can fit in. What are you already doing, and how can you go deeper, make more connections, become more collaborative with those working for racial justice to end health disparities? What new connections might there be in your community to work together? Another unique way of addressing social determinants of health is through social connectedness. This is the model of the Open Table, which started out as an outreach program in a church in Arizona and is now nationwide. In the Open Table, a group of volunteers gather to journey with a person or a family every week for a year. The volunteers are folks from a variety of sectors like healthcare, finance, housing, education, faith communities, and the like. The person or family creates a life plan of their own goals, and the volunteers support them through their connections, knowledge, and personal relationship to help them achieve those goals. The research has shown that this model is particularly effective for those who are socially isolated or who are dealing with several complex issues like mental health, chronic illness, and poverty all at the same time. In Cleveland, many of the open tables are dedicated to those who have aged out of the foster care system. Another truly empowering model is the work of mutual aid, where folks work together to figure out strategies and resources to meet each other's needs, such as food, housing, legal aid, medical care, etc., instead of relying or waiting on the government to meet those needs. The concept is rooted in communities who have been failed by systems of power. And in the US, we have a long history of mutual aid in Black liberation movements dating back to the late 18th century. During the pandemic, many churches have started mutual aid ministries, like Forefront Church in Brooklyn, New York. As Deacon Zenny Fafrak describes, quote, "If you need aid and we have it, we're going to give it to you. There's no parameters or criteria or rules for how you get aid," end quote. This is one of the unique aspects of mutual aid, giving things away without expectations, and thus emphasizing solidarity, not charity, and acknowledging that our well-being, health, and dignity are all bound up in each other. One of the key roles congregations and other faith-based organizations have in a public health response is trust, which brings us to assurance practices. Being a place where people can trust the information, the resources, and the services provided is absolutely essential. Though it's not always the case for everyone who sees communities of faith this way, they are still often known as pillars in the community doing social justice work, And so building off of that relational capital is a piece of the puzzle we have to offer. In these examples, you'll find efforts that focus in on one particular issue. An example of this comes from Greater Cleveland Congregations, a multi-faith coalition that works for systemic change in Northeast Ohio. In June of 2020, they launched their Color of Health initiative, which explicitly addresses racism as a public health crisis. Part of their work has been to create free COVID-19 testing sites at member congregations, especially those located in predominantly Black communities. Given how we have a history in this country of medically abusing Black people particularly, and have violated their trust time and again, faith communities can have a critical role to play in providing culturally competent care in response to COVID-19. As of this recording, Black churches in Gainesville, for example, are currently in the process of becoming COVID vaccination sites to help repair this mistrust and thus to save lives. As one of the church leaders in this effort, Reverend Carl Anderson said in an interview, quote, "People believe in their faith leadership and their pastors. In order to dispel myths, they need to hear it from the people they trust," end quote. And this last point about information is perhaps just as crucial as providing the vaccine itself. A study last fall by the NAACP and the COVID Collaborative found that 41% of Black Americans surveyed said they know little to nothing about how vaccines are developed and tested, which has contributed to more confusion amidst the misinformation that continues to run rampant. Most notably, some believe that they are being injected with the live coronavirus, and thus reasonably think that they have a chance of actually getting COVID from the vaccine itself. Another unique way of utilizing faith communities around public health education is to hold town halls. The Black community accounts for 42% of those with HIV, which is more than any other racial or ethnic group. To respond to this particular health disparity, the Black Church in HIV formed as a national network of faith leaders and community partners to tackle this issue. One of the successful methods they highlight is hosting town halls, because they spark meaningful, well-informed conversations and learning in a place of safety. They start by finding community health experts, which for them would focus on HIV, and then assemble a core team of folks from a variety of perspectives to be part of the event and to help promote it, such as local health folks, members of the NAACP, health clinic staff, and of course, faith leaders. These forums are also often held in churches or other faith-based organizations. Another way hospitals and churches are joining together to become places of healing is in Cleveland's Trauma One Hospital Metro Health, which has teamed up with local churches to provide care for trauma patients after their hospital stay is over. Patients who are predominantly Black and Latinx. Through their new community trauma initiative, the hospital educates local churches on understanding trauma and its lingering effects on communities, and creates a trauma response team within the church, known as a healing circle, a practice used by North American Indigenous peoples. Trauma responders in the churches follow up with patients after they leave the hospital to provide them with support and social services referrals. Reverend Tony Miner, the program director, says that answers to community violence, the answers to trauma, lie within the community. We know we can help these pastors become bridges, building a solid structure for resiliency to emerge within the community. Finally, the UCC's Overdose and Drug Use Ministry is working with churches to dismantle the racist war on people who use drugs, the stigma around drug use, and the idea that people are disposable or that care should be conditional. They provide education, training, supplies of the overdose reversing drug naloxone, and spiritual practices, such as blessing naloxone and honoring those who have died. They are helping faith communities to become part of the life-saving harm reduction movement and to be known as places of safety and support in the community. Finally, these efforts on policy development focus energy on systemic change through laws and legislation. I cannot emphasize enough the role of voting in this crisis. In his book, The Political Determinants of Health, Daniel Dawes explains that voting rights are essential for creating and advancing health equity, perhaps the most important piece, actually. Because when voter suppression occurs, people most impacted by inequities are the same people who are actively locked out of the political system. Further, research shows a correlation between voting behaviors and poor health. And the way to change policy, to change laws, to change funding, is to vote for the policy makers and to have the ability to do so. The UCC's Our Faith, Our Vote campaign has a wealth of resources on faith-based advocacy and voting justice that you should definitely check out. If you're looking for specific policies to advocate for, I highly recommend this list from the Poor People's Campaign that was submitted to the new Biden administration last December. The Poor People's Campaign, in case you didn't know, was actually started by Dr. King and is currently co-sponsored by the United Church of Christ. I'm not going to read this whole list, but as you'll be able to notice if you look it up, all of these recommendations address social determinants of health and are explicitly grounded in racial and economic and environmental justice. A powerful way to use voting rights that many might not know is to introduce and pass what's called citizen-initiated ballot measures, which is a mouthful, but that basically means it gets an issue on the ballot by voters by signing a petition. Due to the long-standing pushback to expand Medicaid by the Missouri legislature, the grassroots and faith-connected organization, Missouri Healthcare for All, mobilized voters to get Medicaid expansion on the ballot. They were not only successful in getting the hundreds of thousands of signatures to get it on the ballot, it also passed, granting health coverage to 230,000 more people in the state. An exciting piece of this story is that Epiphany UCC provided office space for a Missouri healthcare staff member, and Chisholm Member Deaconess Foundation provided funding for that position. I want to give the last words on policy development to Representative Presley here, who recently tweeted about people expressing gratitude for Black women after the election. As she says, quote, "Save your words of appreciation, policy is our love language," end quote. Though this final example doesn't necessarily fit into these public health categories, I want to close with it because I think it's really important for us to consider in the US and for faith communities to be leading the charge in this idea. Truth and reconciliation commissions can be a powerful way to be part of the justice work that is also deeply healing work. The TRC in Canada, which is just one recent example, is where faith communities have been invested and integral to this process, which includes acknowledging the ways in which they have been part of the harm done, as well as how they can be a vehicle for liberation now as well. Hopefully, something you've noticed in all of these examples is how inherently collaborative they are. No one did anything all on their own. They also started out as small and were able to have a direct impact with, not just for, their communities. The prophetic Howard Thurman once said, "Don't ask what the world needs, ask what makes you come alive and go do it." Because what the world needs is more people who have come alive. In response to the reality of early death and preventable suffering of people of color, I ask you to listen to that which gives you life, that sparks passion and movement and a sense of togetherness that we can change this reality. How might God be calling you to use the stirrings you feel in your heart to build the city of God? I hope that not only this talk, but this whole conference offers you the opportunity to envision how we can be vessels for this hope to come alive. Amen. And before I paused for questions and dialogue, Just want to put this slide up about organizations to know, as well as my list of resources, which there are many.
Welcome, Elise. Thank you for that presentation. That was wonderful. That was definitely informative. We have pinned up at the top how people can take action right now here today. But talk a little bit about people who are a little skeptical. We saw a couple of chats about people in the government and they have just a little hope. So just give us a little bit more hope.
Oh boy, yes, that's a great question. So a couple different things. As you noticed in the public health framework, there's room for everybody. So there's room for people to take direct service in their local communities where they are. There's people to focus their energy on changing the government and through policy and putting more effort there. So there's kind of room for everyone. So I would sort of say, give yourself some grace and understanding with where you are in the process and kind of see where you're called to make that change, to make that work. I think too, though there is a lot of very reasonable reasons to have distrust in the government, frustration in the government, if we mobilize together though, that's how change happens. And we really can move things forward if we come together in that way. So it's like, as I see Sandy Sorensen speak out there, it's both and. That's right, Sandy.
Oh, it's both and, yes.
It's always both and. And I think too, there's so much like heaviness and weight and burnout on folks. And so for me, I think it's important, like for the starting place, if you're like, oh, I really want to get involved in this, where is there already that life force, that spark, that energy that Thurman's talking about to get you started? Because even if you're like, well, I'm not a policy person, that's very overwhelming. I'm not a protest person. That's why I also put in the chat, these different roles of the social change ecosystem that's kind of helpful. Even if you're engaged in a food ministry, for example, how are you understanding that ministry? How are you understanding the social and economic problems that created it to begin with? So it's also like that deep self-work of like, are we all on the same page with bringing this together from a public health perspective and a health equity perspective?
That's wonderful. Yes, definitely. And we see that we're going to have all these links later on. Everybody's asking about, are we going to have these links? We're going to have these links and the presentation later on for people to view. Again, this is a lot of content. Thank you. This is a lot of great content. And we're going to get in where we fit in. Thank you, Stephanie, for saying that. Just get in wherever you fit in, wherever you're being called. What are you being called to do next, Elise? What is on your platform for pushing us forward?
Thank you for asking that. So something I did not include in the presentation because it's still in the voting stage is Chisholm has co-submitted a General Synod resolution with the UCC along with Quorum, the racial and ethnic group from the UCC, the Council for the UCC, on racism as a public health crisis. And it's both declaring and responding to it, right? As that's how the resolution is crafted and written, purposely so. And so I think in just a couple of weeks, we'll hear if it's going to go to the floor of Synod for a vote for General Synod in July. And that's where a lot of, on my plate, where energy is going, as well as creating a online course and list of resources and ways to understand this issue. And for me, I think what's really important is that it's not just, it's the grounding it in the hope piece, right? It's not just, here's the list of all of the terrible things that are happening to Black folks, to people of color. It is also, this is what's being done about it. These are solutions that are happening. It's something I was reflecting on this morning too around all of this is like, coming out of Black History Month and entering into Women's History Month. Often we're often hear about stories of, I didn't know that. I didn't know this, Black inventor did this. I never learned that in school. Or, oh, I didn't know this woman was responsible for this. All these different things. And it's like the ideas and the stories and the work for justice and for the solutions have always been there. They're always part of the story. There's never been a time in the history of the United States where, especially like Black folks and Indigenous folks have been like, I don't have any thoughts on how this would be better. Like that's never happened. And it's never happened where the work for community work to make things better hasn't been living. All of this is happening at the same time. And so for me, what's really important is like the narrative of this includes all of these solutions that are happening and ways to fit in. There's lots of folks who have been doing this for forever and generations before us, right? Our ancestors who have knowing this is how we can make things better in a multitude of ways. So for me, that's also really important. And I'm noticing too, Barbara Baylor is, I'm very humbled. She is on this call in this chat. And so I want to uplift her. She's a public health expert and champion in the field. And she says, the work is multifaceted, plenty to do. The UCC Racial and Ethnic Health Disparities Task Force has found that our churches need more education and resources to work on health disparities and promote health equity. Oh, this presentation is a great start. Thank you, Barbara. Good stuff.
Anything else you'd like to close us out with or share with us?
I'm just looking through the chat of folks. There's
Yeah.
always, it's hard to multitask. All of this. Oh, Kirsten Peachy, thank you for saying this. She's from Advocate Aurora Health in Chicago, also a Chisholm board member. And I was talking about there are positive social determinants of health too: social cohesion, economic development efforts, faith and spiritual practice. Yes, 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 amen. And I think too, faith communities are a big part of that. You know, if you look, and I put in the chat too, like the Center for Faith and Community Health Transformation. I don't know if I'm getting that quite right, Kirsten, but the name of your center, you know, that's the language they use, you know, finding the wisdom and the love present in the communities that's already happening and looking that too as social determinants of health. That's really beautiful. And the health equity for health equity, not the health disparities part of looking at it. That's a great framework to include in this conversation. I'm trying to see if anything else is popping up here. Wonderful.
If you have any questions, pop them in the chat. Don't be shy. We're reviewing through the questions here.
Yes. And looking at for us to response outside of our jobs as well as in our work lives. You don't have to wait for agency, organizational change. That's right. Wherever you are, and I feel so passionately about this, that sometimes in advocacy work and spaces, they're sort of like, you know, what you're putting on your resume, like, well, I did this today, or I'm like an official member of this organization, or I'm doing this, or this is what my job title is in this way. But it's also saying something that needs to be said in your PTA meeting at your school. It's saying something that needs to be said in your city hall meeting. It's saying something that needs to be said wherever you're already plugged in. It's having a frank conversation with your doctor whenever you're caring for your loved one and being like, I don't think we're understanding this here. Or, you know, I think I'm not feeling like we're being well treated or well respected here. Like, in saying something in that moment, that is also part of the healing work, how it is already showing up in your daily life. It's not some other kind of thing out here, you know, that you need to like figure out, or, I mean, training's great and all that kind of stuff, but part of us, this healing work is all of our lives, you know, it's this undivided life. And to me, I think that's such an important piece is faith communities and faith-based folks. It's like, this is the integrated life of discipleship, showing up for justice and love and compassion wherever and however we are. All of it counts. And it's all part of it in these ways. Yes.
Yeah, undivided life.
Yes. Somebody's putting up Gary Gunderson's book, The Leading Causes of Life, lives up what Kirsten is saying. Yes, yes, amen. Thank you for that. Another good one that I didn't bring in here, but that's just recently published, is The Sum of Us by Heather McGee, I believe. And she's talking about, you know, sort of referencing Jonathan Metzel's work a bit about, you know, that racism in the policies, racist policies impact everybody. And so it's also like noting, like, you know, the amount of disparities that we have in health and wealth in our country really is broadly speaking. So there's also just ways, a variety of ways to look at all these things. Sandy Sorensen is also saying, if you think you are too small to be effective, you have never been in a room with a mosquito. Yes, that's a proverb, I believe. Yes, that is right. We all have our place to make a difference. And I think we all can. And that's what I'm hoping too, like I said at the end of the presentation, not that just this workshop, but this whole conference, this whole also being part of Chisholm, can invite us all to think about these things in a different way. And that's really also the value of grounding it in a public health framework, grounding all of these different sectors of where we're coming from and the work that we do for this collective effort, always looking at it from that health equity lens, and this racial health equity lens is just really important. And it rallies us to come together and not be siloed, and to have a deeper understanding of the intersections of all of these different things. So yeah. Oh, and Leslie Jackson saying, yeah, the links will be posted, and access to the videos will be happening shortly after the conference. All of the conference videos will be available in the forthcoming days and weeks. Days, I think, according to Tyler, our tech person. Kirsten's also saying another good book is Deeply Woven Roots, that explores the 8 strengths of congregations for addressing public health and social determinants of health. That's perfect. Thank you for that. And on, I think, for the links, Brenda's asking about where they'll all be available. I believe we'll be putting them on the Chisholm website somewhere, probably associated with the annual gathering. Yeah, and that's what they're saying.
Okay. Yeah. Mm-hmm.
Yeah, we'll have a resource library. Yes, yeah.
Yeah. Both and they'll be in the communique and in the resource library.
Both and for everything. That's right. Yes. So look forward for the General Synod resolution that Chisholm and Quorum have submitted, and we've also got supporters that weren't allowed to have their names on the resolution itself, like Advocate, like A Just Harvest, like Odom, and some other folks who are actively supporting this piece of resolution for the denomination. And so that's really exciting. And this course that I'm creating to kind of help us walk us through this understanding of, here are the issues, and also here are the visions of like where people are doing this well, where they're responding to it well, where they're bringing new life and solutions to all of these different things, to help you imagine, where and how is God calling me and my unique gifts and what I have to offer the world into this issue. Because really, as I said at the beginning of the presentation, health equity, that is the city of God. That is what Jesus was talking about. That is what all of the prophets were talking about, especially Isaiah and Amos. This is this world where there aren't these barriers to preventable suffering that we can actually change. That is the city of God. That is what we as Christians are called to do. And so finding where our place is in that ecosystem, I think, is just so essentially important. And Elisa Jackson saying, yes, there's so much self-blame among people of color for various societal plights. The offering of macro level perspectives and concrete examples of blatant discrimination is validating in its own right. Yes, thank you. Wonderful. Well, good. Is there any other, I want to leave the chat open for another minute. Any other thoughts or questions you have for me while you have me here? You can always, as a Chisholm person in particular, you can always email me, reach out to me anytime. I'm very happy to talk about this. I'm very passionate about it. It's all of the things. That's why I said it's very content heavy, but really to talk about this well, had to really bring up a lot of different angles to it, because it's so multifaceted. Just give another second there. Paula, do you have any thoughts or ideas on all this?
There's a lot to consume here, but I do thank you. I want to thank you for leading and framing this discussion. You've done a really excellent job with this. So thank you so much from the Chisholm team, from all of us, and from me too.
Awesome. Thank you.
So I guess there's no more in the chat today. You've done a good job, explaining everything, and everybody's ready to dive into these links. I know I am. So don't
Awesome.
take action and sign the action alert from Justice and Witness. And
yes.
we want to police for giving us reason to have hope and responding to racism as a public health issue, and for engaging in this conversation. So thanks so much, Elise.